So the title of my presentation is Adaptive Preservation and Compensation in Language and Numerical Cognition after Left Hemisphere Damage, which is an exploratory case series evidence. Well, I would like to thank you, first of all, to having me today as a speaker to share my insights on brain and cognitive science, specifically on language and mathematics in aphasia. So let's start with today's agenda. So I will start with a bit heavy background on aphasia and the classification, some neuroanatomical foundations, and I will introduce a combinatorial merge mechanism, as well as some insights on formulaic expressions. Then I will present my own research results. So I would like to start directly with aphasia. Well, aphasia is a language impairment as a result of cerebrovascular accident, which is usually the case of stroke, traumatic brain injury, or progressive neurodegenerative disease, which is usually primary progressive aphasia, which are caused by dysfunction in specific brain regions, which is usually in the left hemisphere due to the cerebral lateralization of language. Majority of population has left hemisphere dominance for language, with some cases of some instances of right hemisphere or both hemispheres, but usually it is left hemisphere. So it's also wise to look at Damasio's perspective, indicating what is not aphasia. So aphasia is not a disorder of perception, such as in deafness, where language comprehension is damaged. However, the reason is because of the auditory channel of the central nervous system, not language per se, with intact comprehension, such as through vision or touch. And it is not a disorder of movement, such as the case of dysarthria, where the speech apparatus is impaired, and this affecting the articulation and implementation of speech sounds, with an intact language formulation, such as a written form, maybe. And it is not a disorder of basic thought processing, as in the case of schizophrenia, where the thought process is distorted with a more preserved language mechanism. So when we look at classical aphasiology and classification, we see aphasia as a syndrome that are identified by a consistent set of language deficits resulting from focal brain lesions, usually stroke and traumatic brain injury, by excluding progressive neurodegenerative conditions, which is primary progressive aphasia. So in this perspective, aphasia is more like an acquired disorder by excluding the primary progressive aphasia, which is neurodegenerative conditions. So Boston School of Aphasia, which is widely accepted and known, identifies 8 major types of aphasia regarding some language domains. First one is production, referring to how speech is generated, focusing on fluency, grammar, and some motor aspects of language. The other one is a comprehension, which refers to the meaning, how meaning is understood from spoken or written language. And the last one is a repetition, basically the ability to repeat words or sentences. And it is wise to note that the deficits in these domains can overlap across syndrome, such as repetition might be impaired in both Broca's aphasia and in conduction aphasia. However, each aphasia type has distinct underlying mechanism and distinct clinical features. So these 8 classifications include Broca's aphasia, Wernicke's, global, conduction, anomic, and 3 types of transcortical aphasia. However, today's focus is going to be on Broca's aphasia. So let's have a look at prototypical clinical features of Broca's aphasia. Well, let's start with the production. When we look at the production of patients with Broca's aphasia, we see very non-fluent, very slow and effortful telegraphic speech. Well, by telegraphic speech, I mean the similar logic with the telegraphs from old time, part by part or chunk by chunk, which I will give you an example later in this section. We also see some co-occurring motor issues, such as apraxia, where the motor planning is damaged, or dysarthria, which I just mentioned, which is more muscle or movement problem. However, due to some complications, those might also co-occur in Broca's aphasia. And one of the most significant feature of production of Broca's aphasics is the grammatic output. Well, the tendency to omit function words or morphology. Well, function words are the ones that are more grammatical. So we can basically classify words into two categories as function and lexical. Lexical words are those that have some semantic meaning by themselves, like some nouns, verbs, adjective, and verbs, while function words are more grammatical, more functional in language, such as prepositions, determiners, and so on. And morphology is concerns the affixation in language, let's say, in very basic term. In English, for instance, those ing, s, those suffixes that concern the change the meaning of the word. So we see omission of those, so such as the production of a patient with Broca's aphasia for a sentence like "I'm going to the supermarket" would be, after omission of function words and morphology, would be like "I go market." Something like this would be probably by omitting the function words and the morphology, like amizar is omitted, ing is omitted, and to preposition is omitted, and so on, by focusing solely on the lexical items. And on the other hand, we see the more, let's say, reliance on nouns over verbs, and also for our case today, more importantly, the reliance on formulaic expressions, which I'll be explaining further in further slides. And when we look at the comprehension, we see relatively preserved language comprehension, especially for simple and familiar daily life language. However, comprehension also gets some complications with further complexities in syntax. So, for example, in English, a sentence like, "I saw the man who was standing in front of the building, which was built in 1945. So such sentences with embedded clauses would be very difficult for patients with Broca's aphasia to understand. On the other hand, in literature especially, there's a classical comparison between object relative clause versus subject relative clause. Well, here, for example, the dog that is chasing the cat, which is subject relative clause. Object relative clause is the dog that the cat is chasing. This is object relative clause, and this is much more difficult for patients with Broca's aphasia to comprehend, and also for neurologically healthy people. It needs the studies show that we also spend more time to comprehend object relative clauses. However, this is for Broca's aphasia case, this is even impossible to understand. And when we look at repetition, well, we see a better pattern in repetition compared to spontaneous speech. However, still the repetition is full of mistakes, especially some phonological paraphasias or even omission. So, for example, for the word dog, patients might change some sounds. So instead of dog, they might say gog, or they might omit a sound fully, which is like instead of dog, it's og, grati. And when we look at the lesion site, we see usually left inferior frontal gyrus, and specifically in Broca's area, which I'm going to introduce you more. So Broca's area is a specialized region within the left inferior frontal gyrus, actually. Although in most of the cases, they use substitutionally Broca's area and left inferior frontal gyrus. But if you look at the picture on the left, the first part of the picture showing the lateral view of the brain, there's an M-like pattern here. So for the second one, it is much obvious. So let's have a look at the second one. So there's an M shaped like a place, so-called inferior frontal gyrus. So this M-like shape is inferior frontal gyrus. And when we divide them, actually it's divided by itself. And when we look at this division, we see 3 parts. And this excluding the, let's say, anterior part, the pars orbitalis, the rest, the pars triangularis and pars opercularis, those 2 are the ones that compose the Broca's area. However, again, in literature especially, we see the substitutional use of Broca's area and left inferior frontal gyrus. But importantly, this is critical. It has critical role in language and cognitive processing, such as motor planning for speech, syntactic processing, hierarchical structuring, and so-called merge operation. And for our case, hierarchical structuring and merge operation is the significant one, let's say, which is our focus today as well. So the combinatorial mechanism in language, which is merge, let's have a look at this. So, well, merge is a basic operation that combines 2 elements to form a new unit in language. So for instance, we have mental lexicon that, let's say, we store the lexical items. So we take 2 elements from our lexicon, such as boy and the article the, and we combine them, and we, at the end of this combination, at the end of this merge, we have the boy, which is a new unit. And by repeating this simple step, we create hierarchical and recursive structures, which allow us to generate infinitely many sentences from a limited set of elements. So we have the boy, which is merged, okay. And let's take fast and run. So we have 2 new items, we merge them, and then we got run fast. So we have 2 groups now, the boy and run fast. And now we merge them again, and then we got the boy runs fast. And by doing so, we have infinitely many sentences. We can have infinitely many sentences from limited set of elements. And merge actually shows how complexity in language can arise from a very simple cognitive principle regarding the Chomsky's argument. So here I have a very, very basic representation of a so-called syntactic tree, which represents how language is managed in our mind. So, well, language is something hierarchical. Although we say linearly and we write linearly, like in the case of the first line in the picture, like merge with parentheses, it is represented as a hierarchical structure. So if you can look at the diagram, the image, at the bottom of the diagram, we see this distinct, the unique lexical items, which are the boy runs and fast. So by combining them and recombining, also we can say merging, remerging, we got the sentence, the boy runs fast, which can be very complicated further merging operation. However, again, this is represented with merge from a very simple cognitive principle. So when we look at this merge mechanism in the brain, we see activation reliance on left hemisphere, especially in Broca's area, let's say around inferior frontal gyrus and Broca's area. And I put a picture from Leo's and colleagues' study in 2023, where they compared word lists and structures. So the structure is more like an merging operation. So basically, it is like, for our case especially, it is merging versus non-merging word list. And they observed activation in Broca's area and also in inferior frontal gyrus for merge-like expressions, which is called as structure here, while word list activated more temporal regions rather than inferior frontal gyrus. So this merge, sorry, is there a problem? I assume it was a mistake, I don't know. Well, so we also see this merging or this hierarchical structure in other cognitive domains as well. So it's not just a pure linguistic operation. So merge is also a domain general mechanisms, which we can see instances in music. There's a background noise. I think fine now. I will continue. So merge is also a domain general mechanism, as I said, especially in music, tool use, action planning, and mathematics, we can see. So for example, in music, we see notes and chords, which are merged or combined, let's say, into more complex melodies, and so that we have music, which is very similar to the language, what we do in language. And on the other hand, we have action and cognitive control, where discrete motor actions are organized into coordinated, sorry, sorry, discrete motor actions are organized into coordinated goal-directed sequences, such as playing an instrument or dancing, where again the coordinated goal-directed sequences are combined for a hierarchical structure. And for the neural basis, we see an overlap between language and music in action. Again, around Broca's area or inferior frontal gyrus. For our case today, especially mathematics, or let's say numerical cognition is the significant one. We also see a similar pattern in mathematics, such as taking 50 and 5 and merging them or combining them to get 55. Much like merging words in a language, actually. And also we see the, again, similar neural mechanisms involved in mathematical merging. So the left inferior frontal gyrus is crucial for building mathematical structures following hierarchical rules. Again, very similar to its role in language syntax. And here there's a study from 1999, Siena and colleagues, where they compared exact calculation, which is more like a merge, and approximation. And they observed more activation in left inferior frontal gyrus for exact calculation, while approximation activated more visual spatial networks in also in parietal regions. So another story is formally expressions. So sorry. So formally expressions are, as I mentioned, are relied on in aphasia, especially in Broca's aphasia. So what are those? Let's have a look at what are those. Well, those expressions are fixed and overlearned phrases that are not generated through the standard grammatical rules. Instead, they are stored and retrieved as whole units. They are more automatized. So these are such as idioms, kick the buckets in English, exclamation like wow, oh my god, and so on. Discourse markers, well, so, or binomials, which are fixed word pairs like salt and pepper, pen and paper. And those expressions, their order is influenced by phonological and semantic factors. And they are characterized by their fixed structures and intonation patterns, which at the end make them both efficient and easily recognizable. So for example, let's have a look at this salt and pepper. Well, it is salt and pepper. It is not pepper and salt. So the structure is fixed, and also there's an intonation pattern. So it is like salt and pepper. It's not salt and pepper. Well, still valid, of course, but this fixed intonation pattern also affects is affected by nature of the formulaic expressions. And when we look at the neural basis, we see those expressions rely on right hemisphere and basal ganglia. The data comes from different clinical populations, such as Parkinson's disease, where basal ganglia are impaired, let's say. And in this case, the studies show that in Parkinson's disease, the use of formulaic expressions are not as much. They don't rely on formulaic expressions. Well, the data from schizophrenia is preliminary, as I remember, which needs further investigation, where right hemisphere might be impaired somehow due to the psychiatrical situation, which uses less formulaic expressions. But again, this is a preliminary results. But for our case, especially right hemisphere and subcortical damage, like in aphasia with right hemisphere damage, or atypical aphasia where subcortical damage is there, we see less tendency on formulaic expressions. And Alzheimer's disease, which is, well, in Alzheimer's disease, there's also an reliance on formulaic expressions, which is not surprising due to the fact that in Alzheimer's disease, typically hippocampuses are the ones that are impaired at the beginning stages, especially. So those right hemisphere or basal ganglia are intact per se. So that is why there might be a reliance on those expressions. And for aphasia, at least in Broca's aphasia, they remain accessible, even though the syntax is impaired. However, this is not very significant regarding formulaic expressions because they are not generated through standard grammatical rules of a language, as I mentioned before. So let's have a look at the case of aphasia precisely. Well, so we said while merged language depends on Broca's area or left infrafrontal gyrus, formulaic expressions rely more on right hemisphere and subcortical structures, especially basal ganglia. So patients with aphasia, especially Broca's aphasia, let's say, they usually retain formulaic language despite this impaired syntax. And this impaired syntax is due to the Broca's area or left infrafrontal gyrus. And this evidence from neuroimaging studies show a novel language activation in left infrafrontal gyrus, while this automatized formulaic speech activates more right hemisphere or basal ganglia. So right hemisphere and subcortical damage reduce formulaic use, which highlights the role of their role in automatic speech. So this supports, and this is supported by, we can also say, a dual processing model of language, so-called, where left hemisphere is for more like novel expressions, and for our case, we can say maybe merged syntax, while right hemisphere and basal ganglia is for more stored like expressions. Accordingly, the first question of mine is how individuals with Broca's aphasia perform on the task with merge versus formulaic expressions across both language and mathematics. Well, this question investigates the cognitive distinction between this combinatorial merging and this automatized retrieval of formulaic expressions. And for merge operation, we have active construction in language, such as forming phrases or solving basic mathematical expressions like 4 plus 7. And for memory retrieval, we have formulaic expressions in language, such as specifically binomials, such as salt and pepper. And for mathematics, we have multiplication table, like 6 times 6, 36, 2 times 2, 4, and so on. But however, for today's presentation, the second question is more significant. So, which is, do patients with Broca's aphasia demonstrate the same deficits in both linguistic merge and mathematical merging tests, while retaining both linguistic formulaic expressions and mathematical formulaic expressions? And this question explores the shared neural base of merging process across language and numerical cognition, which is left infrafrontal gyrus or Broca's area. And this implies that damage to these areas might impair both linguistic and mathematical merging, while remaining preserved formulaic expressions across, again, language and mathematics. So for this study, I'm going to present five patients with Broca's aphasia. In original study, there are 2 other patients, 1 conduction and 1 global aphasia. But for today's presentation, I have only 5. So those patients, all of them are the patients with Broca's aphasia, and they are Turkish. So the research is done in Turkish. So accordingly, we have 4 categories. The first one is linguistic formulaic expressions, which are familiar overlearned binomials from everyday Turkish. So here, for English, or maybe for your native language, if you're not native of English, they might not sound very familiar, but for Turkish, they are very familiar and overlearned binomials, such as cheese and bread, fork and knife, tea and coffee, pen and paper, rubber and polish. For mathematical formulaic expressions, we have well-learned multiplication facts, which are those like 6 times 6, 2 times 2, 3 times 3, and so on. And for linguistic merging expressions, we have null nouns combinations with no pre-stored memory representation, which are derived using a noun of binomials that I use for linguistic formulaic expressions. So we had, for instance, pen and paper for linguistic formulaic expressions. For linguistic merge requiring expressions, we have pen, which is similar, which is same. But this time for merging, I added tomato, for example, which has no semantic relation or any other relation with pen. And for mathematical merge requiring expressions, we have simple addition problems requiring active computation. So the numbers are same, at least okay, the numbers are same, at least the first ones. So for example, for 4 times 4, for mathematical formulaic expression, for mathematical merging one, we have 4 plus 7. The first numbers are same here. So here, there's an example of stimuli. So first of all stimuli were received auditorily regarding the reading deficits in Broca's aphasia, possible reading deficits. And all options were presented visually and due to the production deficits. So for the linguistic stimulus, auditory stimulus, which is tea and coffee, participants chose among one picture of tea and coffee, which is correct answer. The second one is semantically related distractors, so tea and biscuits, which go nicely together, let's say. Semantically related distractor. And the third one is a distractor from another linguistic category. Well, for this case, for tea and coffee, our linguistic auditory stimulus, which is formulaic expression. So for this case, distracted from other linguistic category would be merging one, which is tea and shoe, for example. The same, or let's say similar logic was applied for mathematical stimuli. And here, for example, we have 4 plus 7. And for these participants had correct answer, which is 11, and then one less, which is 10, and one more, which is 12. So results show some interesting insights. So here the blue is linguistics and the orange is mathematical one. So first of all, let's have a look at formulaic expressions. So linguistic formulaic expressions, well, it was a near perfect performance across all patients, which can support the idea that formulaic expressions rely on memory retrieval, which is regarding the theory, which says basal ganglia and right hemisphere, not active syntax of Broca's area. And mathematical formulaic expressions show the similar pattern, highlighting high accuracy on the overland multiplication. Sorry, I have a really hard time with this multiplication facts, and which also supports the idea that retrieval mechanisms remain intact, independent of Broca's area. But things were a bit different in merge mechanisms. Well, in linguistic merge, all patients with Broca's aphasia performed at ceiling. Well, here there are some insights. So patients likely used some semantic or contextual cues, such as what I observed was focusing on the final word in, for example, pen and tomato, as compensatory mechanism, maybe. And this can suggest residual merge ability or semantic-based compensation, especially under low task demand, regarding given the low task demand of the linguistic merge task. And lastly, the mathematical merge, which showed greater variability and lower scores, which might suggest numerical cognition is more sensitive to Broca's area damage and individual lesion profiles. Or we can also interpret this as, well, in mathematics, there's no semantic or contextual cues. So that's why in mathematical merge requiring task, the patients performed lower scores. So no compensatory strategies lead to greater difficulty. We can also interpret the results accordingly. So the linguistic merge task might not have been challenging enough, which potentially masked deficits through semantic compensation. But on the other hand, a mathematical margin task, although there was a variability, might indicate some degree of impairment, which suggests further that merge operation, particularly under increased computational demands, are indeed affected, especially lack of any compensation compared to language. And of course, personal differences and compensatory strategies further complicate the picture, highlighting the need for more challenging and isolated tasks, especially with some neuroimaging studies in the future. So in conclusion, well, patients with Broca's aphasia retain strong capabilities in retrieving overlearned formulaic expressions across both language and mathematics. But the results indicate emerging evidence of impairment in active merging processes, particularly in the mathematical domain. Also, the nearly ceiling level performance might might reflect compensatory strategies and low test complexity, which suggests that in the future research, it should be employed more challenging paradigms to fully characterize the deficits in March operation associated with Broca's aphasia. Well, yeah, that's it. Thank you so much.
So for me and for the team, it's a great pleasure to welcome you today to this webinar. This webinar is a space dedicated to scientific exchanges, innovation, and the promotion of a new generation of young researchers. As you know, my name is Dr. Habshi Nawel, assistant professor in neurosurgery at France Fanon University Hospital Center in Bida. Bida is located in Algeria. And today, I have the great honor of presenting our conference entitled Exploring the Brain Tumors from the Shadow to the Light with the use of immunohistochemical markers and histological grids. Throughout this presentation, we will explore together the fascinating and complex world of the brain tumor, focused only on two brain tumors, the glioblastoma and pituitary adenoma. And we will highlight the importance of one technique named immunohistochemistry with the use of its marker and doing the histological grading. When we use this technique and do the histological grading, we understand the tumor behavior. Today, this conference is especially meaningful for me. Why this? Because I am joined today by two brilliant students, brilliant master student in biology. The first one is Rasha Zenasni, and second one is Buranu Lea, whom I had the privilege to supervise them and product some dissertation, some scientific dissertation. And today we will show to you our results. Their dedication, scientific rigor, and the passion for the research truly embody the promise for new generation of scientists. And for me, it's a great pride to see them presenting their findings and contribute to the dissemination of scientific knowledge. Our goal today is not only to share the results, but also to inspire and encourage the young researcher to pursue their dreams, to believe in their ideas, and let science shine beyond the borders. Today, together, we will move from the shadow to the light, discovering how immunochemistry and histological analysis can help you to understand the mechanism of the brain tumor behavior. And consequently, we can open a new perspective for the diagnosis and for the therapy. This is why I want to show you the results of our work. And also, I wanted to encourage the new generation to believe in their ideas and also share their experience, their result in order to shine the sciences beyond the world, beyond the borders. So now I wanted to present to you my brilliant students. The first one, Rasha Zenasni.
Good
Rasha,
evening,
you
everyone.
are here?
Yes, doctor. Good evening, everyone. My name is Rasha Zenasni. I'm an Algerian researcher with master degrees in cellular physiopathology. My current study focuses on the role of immunohistochemistry in the management of glioblastoma. And today I will explore the key immunohistochemistry markers used in GBM and understand their role in the diagnosis and treatment of these tumors.
Leah, you are here. You can present yourself.
Yes, doctor. Good afternoon, everyone. This is Leah Bourneau, an Algerian researcher with a master's degree in cellular physiopathology. I would like to
Yes.
start with a genuine pleasure to be here, basically. And I'm delighted to open this session with a brief introduction to set the context of this presentation. Brain tumors represent one of the most challenging subjects in neuropathology due to their complexity and diverse behavior. This presentation focuses on glioblastomas and pituitary adenoma, two tumors with divergent natures yet united by the importance of immunohistochemical markers and histological grading in their diagnosis and prognosis. Immunohistochemistry acts as a bridge between morphology and molecular biology, enabling pathologists to identify tumor lineage, assess aggressiveness, and even predict treatment response. So through this approach, the true nature of these tumors moves from shadow to light, providing a clear understanding of their biological identity and clinical implications. So the main objective of our presentation is to highlight the diagnostic and prognostic value of integrating immunohistochemistry with histological grading to refine diagnosis and guides for better therapeutic management. Let's begin with the immunohistochemistry technique. So what exactly is this technique and why is it so important in tumor diagnosis? AHC is a laboratory technique based on the uses of specific antibodies to identify antigens by staining. This allows us to visualize proteins that are unique to certain cell types or tumor origins. So it has become an essential examination method for the identification and classification of carcinomas. And over the past decade, the accuracy and development of specific immunomarkers and the clinical validation of effective panels have improved considerably, making it an independent and indispensable tool in the diagnosis of pathology. So the purpose on the role. When it comes to brain tumors, AHC provides crucial diagnosis and prognostic information. It allows for the differentiation of tumor types, such as distinguishing a glioma and a pituitary adenoma. Also, for identification of molecular markers relevant to tumor origin and prognosis, and the evaluation of the tumor's proliferation and aggressiveness supporting histological grading. Thanks to this function, now we can move on to the second key element of our presentation, histological grade and prognosis value. The histological grading of brain tumors is essential to evaluate their aggressiveness, proliferative potential, and clinical prognosis. Each tumors have their own grading systems that help predict behavior, recurrence, and even the response to treatment. During our master's degree thesis, we had the privilege of working on a retrospective and anatomopathological study under the supervision of Dr. Habshi, focusing specifically on the two types of brain tumors, glioblastoma and pituitary adenoma. So in this study, we analyzed and compared both of these tumors, in which we collected and analyzed medical records for the making of retrospective study. The collected informations were organized and presented in the form of statistical data, allowing us to better understand the distribution and clinical characteristic of these tumors. Then in the anatomopathological part, we used immunohistochemical technique to study tissue sample, identifying key markers and observe how these markers relate to tumor types and behavior. So now I will be passing the floor to Rasha so she can present her study on glioblastoma.
Thank you, Leah. For our first tumor, I will start by defining GBM. Glioblastoma is the most common and aggressive malignant primary brain tumor in adults, classified as WHO grade 4 neoplasm originating from astrocyte. It's characterized by extremely rapid and invasive growth, and its pathological hallmark feature include prominent area of necrosis and microvascular proliferation. Molecularly, GBM is predominantly ADH wild type and often show alterations such as EGFR amplification. Clinically is present with progressive neurological symptoms like persistent headache, nausea, focal deficit, or seizure. Despite multimodal treatment involving surgery, radiation, and chemotherapy, the overall prognosis remain very poor. So for treatment, the therapeutic approach to newly diagnosed with GBM follow a structured path. It begins with clinical suspicion. The detection of this type of tumor is by physical exam using CT scan or MRI, followed by maximal safe surgical resection. Then comes the cornerstone radiotherapy using X-ray, gamma ray, photon or proton, and chemotherapy currently with temozolomide, followed by 6 adjuvant cycle. Before treatment, there is a diagnosis, and here the pathology become our compass. Immunohistochemistry allow us to decode the tumor identity, and we have 6 key markers to get us. First, next slide, please. First, the GFIP. Second, the IDH1 or 2. And in the third position, the P53, the EGFR, the Ki67, and finally, the OLCIAS. And now let's look at each marker and its role in diagnosis and treatment decision for glioblastoma. First, the GFIP. The positivity of this marker confirms astrocytic differentiation. It tells us that this tumor is originating from astrocytes. E.g., the ID, in the second position, we have the IDH1 or 2. We have 2 kinds, the IDH mutant and the IDH wild type. One have better prognosis than the other. For P53, we call it the guardian of the genome. When it's mutated, it reflects a breakdown in cell control in GBM, and it's helped to refine prognosis and may influence therapeutic decision. The EGFR amplification. The amplification of the EGFR or mutation here signals a pathway of growth, generally aggressive, and it's opened the door to target therapies. For the Ki67, a proliferation index, when it's over that 20 or 13%, it indicates a very aggressive tumor and snapshot of how fast the tumor is moving. Finally, the OLCIAS, its nuclear positivity in gliomas might get classification and in some contexts therapeutic inhibition. Now I'm going to show you the implication of molecular biology, specifically MGMT gene promoter methylation. While MGMT promoter methylation statue is technically a molecular analysis by PCR and not a immunohistochemistry technique, this gene statue is one of the most important prognostic and predictive factor in GBM. It's a predictive factor for response to a treatment with temozolomide, and methylated MGMT promoter respond better to adjuvant chemotherapy and have significantly longer progression-free survival. Next slide. Now we move to retrospective study. This one was conducted at Neurosurgery Department of Mustafa Basha in Algiers under the supervision of Dr. Habshi. It covered 3 years from 2020 to 2023 and included data from 63 patients. In our cohort, next slide. In our cohort, the average age was 58 years. The highest number of cases was seen in the 61 and 78 age groups. There was also a clear male predominance. For location, most tumors were located in frontal lobe, with most common symptoms like headache, vomiting, and epileptic seizure, and they depend on the location of this tumor. The second study is a prospective study conducted at an anatomopathological laboratory of Nafisa Hammoud in Algiers, and it's focused on immunohistochemistry profiling of glioblastoma. And let's see together the important marker studies. The first, the key 67, height expression or positivity show us the aggressive, rapidly proliferating nature of these tumors. For the GFIP, positive in the most glioblastoma cases, confirming the glial origin of the tumor and supporting a high degree of aggressiveness rather than a metastatic origin. In the third position, we have the P53, often positive in GBM, a common deregulation of this protein tumor suppressor pathway in our cohort. Finally, the OLIC2, diffuse in 18% of GBM cases that support a primary diffuse glioma phenotype. This slide shows immunohistochemistry staining of giant cell GBM using 3 important markers, the 2-panel GFIP and P53. On the left, we see GFIP staining. The brown color in cytoplasm confirms the glial origin. And on the right, we see P53 staining. Strong nuclear positivity suggests mutation of this protein, and we can see the blue color in nuclei. Next slide. The bottom images show OLIC2 staining. For A, we have a negative zone, meaning OLIC2 is not expressed in this area. And for B, we see positive control confirming OLIC2 expression that can help us in the tumor classification. Together, this marker helps and confirm the diagnosis for the GBM and give us information about the tumor origin. And now I will hand over to Leah, who will introduce another type of brain tumor.
Thank you, Rasha. Now we'll move on to the second tumor, the one I focused on in my master's degree thesis, pituitary adenoma. Also known as pituitary neuroendocrine tumors or PITNETs. They are benign, slow-growing tumors of the pituitary gland, most commonly cause of hormonal imbalance in adults, producing symptoms related either to excessive hormone secretion or a mass effect on surrounding structures. PITNET has many classifications, yet for the purpose of this presentation, I will only mention these two. First classification is the functional classification, which is related to the hormonal secretion. First type are the functional or also called secreting adenomas, which are the ones with excessive production of specific pituitary hormones. And the second type is the non-functional or non-secreting adenomas, which simply don't have a clinical significant secretion. Second classification is the tumor type determined by the immunohistochemistry. This classification presents three main lines according to their expression factor, yet just for an explanation space. The lineage markers are transcription factors that guide pituitary cells during development to become specific hormone-producing cells type. So it simply indicates the origin of the cells expressed with these markers. So first one is PIT1, includes somatotroph, lactotroph, and pterotroph adenomas. They secrete growth hormone, prolactin, and thyroid stimulating hormone. Second one is TPIT, corresponds to corticotroph adenomas, which secrete ICTH. And finally, SF1 includes gonadotroph adenomas producing FSH and LH. Additionally, we have complementary markers that we will be mentioning later on. So clinically, PITNET can manifest either through hormonal overproduction, leading to specific syndromes, depending on the over-secreted hormone, or through mass effect when the tumor compresses adjacent structures. And the diagnosis at first relies on hormone testing and MRI. For the application of the immune histochemical technique in pituitary adenomas, it allows us to identify the tumor cell lineage and hormonal profile, allowing pathologists to determine exactly which type of pituitary cell the tumor originally is from. According to 2021 WHO classification, it is now recommended to use this technique for a more precise subclassification, since each subtype has a specific behavior and prognosis, impacting the clinical management and treatment decision. Now that we understand the importance of subclassifying pituitary adenoma, let's look more closely at the main histoimmunochemical markers used and their therapeutic implication. The first group of markers are the lineage-specific transcription factors, which indicate the functional identity of the tumor cells. So we have the first one, PIT1. This marker confirms hormonal secretion origin, and then TPIT marker identifies corticotroph tumors, yet it is also particularly useful because it can help predict recurrence after surgery. And SF1, this one is usually seen in non-functional adenomas, meaning the tumor cells don't over-secrete hormones, but may still cause a mass effect to their growth. There are also general and complementary markers that play a crucial role in confirming and refining the diagnosis of PITNETs. Let's start with chromogranin A. This is a classic neuroendocrine differentiation marker. It positively helps confirm the neuroendocrine nature of the tumor and therefore if it's pituitary origin. Next, we have cytokeratins 8 and 18, which highlight the epithelial phenotype of the cells. Their expression supports the adenomatous nature of the tumor, helping distinguish PITNETs from other non-epithelial lesions that may occur in the cell region. Final marker is GATA3 and ER alpha, used as complementary lineage markers. They help to refine the tumor subtype and assist in differentiation diagnosis. And lastly, the most important marker when it comes to tumor proliferation, the Ki-67 index. This marker reflects the rate of cell division inside the tumor. When Ki-67 value is higher than 3%, it indicates the tumor cells are dividing rapidly, which means the tumor is more aggressive and has a higher risk of recurrence after treatment. Because of this, a high Ki-67 index can also influence therapeutic decisions, such as whether to recommend additional radiotherapy or closer post-surgery monitoring. Now let's move on to histological grading. A clinical pathological classification set by Trias in 2013. It grades pituitary tumors based on two main criteria, proliferation and evasion. For the proliferation aspect, we look at markers such as Ki-67 index higher than 3%, more than 2 mitosis per 10 high power fields, and P53 positivity in at least 10 nuclei per 10 fields. Second, the invasion is determined radiologically. For example, when the tumor extends into the cavernous or sphenoid sinus. Based on these factors, tumors are classified as 5 grades. We have the first grade, grade 1A, it is a non-invasive tumor. The second grade, 1B, also non-invasive, but proliferative. Grade 2A, invasive tumor, and grade 2B, also invasive, but it is proliferative. And for the grade 3, which is a rare grade, which represent a metastatic tumor. Next, the immune histochemical markers and their therapeutic application in PITNETs. In drug treatments, by identifying the tumor's hormonal lineage through immune histochemistry, doctors can move toward targeted therapies instead of using the same treatment for all types of adenomas. So for the adenomas prolactinoma type is treated with dopaminergic agonist, which help normalize prolactin level. For the acromegaly caused by excessive growth hormone, we use somatostatin analogs to reduce IGF-1 production. Cushing's disease treated with adrenogenesis inhibitors, which help limit cortisol secretion. For central hyperthyroidism, we use somatostatin analog used preoperatively or after surgery failure. And finally, for the non-functional adenomas, generally not sensitive, so they are primarily managed by surgery. Next, the histological grading and therapeutic planning. So when we have the first grade 1A, it has a low recurrence risk, so it is controlled medically or with observation post-surgery. And for the second grade 1B, it has an increased proliferative potential with invasion. It requires closer follow-up due to possible progression. For the two grades 2A and 2B, to represent a local extension, so here we do the surgery. And for grade 3, that has a high proliferative index and invasive behavior, indicating an aggressive tumor. In this case, doctor consider adding radiotherapy and rigorous follow-up. So in the treatment, we have a multimodal strategy by drug therapy for hormonal active adenomas, surgery for macroadenomas or visual compromise, and radiotherapy or radiosurgery reserved for invasive or recurrence cases. Now I'll be sharing with you the results of our retrospective and clinical study on PITNET. The retrospective study was done in neurosurgery department of Prince Fanon Hospital of Blida in Algeria, covering a duration of almost 10 years from 2015 to 2025 by using medical records of 90 patients. Starting with the sex distribution, our study included 58 men and 32 women, showing a clear male predominance among the cases analyzed. For the age, the distribution was homogeneous with a minimum age of 40 years old to a maximum age of 77 years old, with an average age of 45 years old. And the highest prevalence was observed in the 40 to 50 years old age group. For the histological grading, we identified 8 cases of grade 1A, 10 cases for grade 1B, 32 cases for grade 2A, and 37 cases for grade 2B, while no cases for grade 3 were observed. Grade 2B showed the highest frequency with the 42% of our cases. Out of the 87 patients, 14 experienced tumor recurrence. Among them, 7 cases belonged to the grade 2B category, highlighting the possible association between higher histological grade and recurrence risk. Then the prospective part of the study was conducted in the anatomopathology laboratory of Nafisa Hammoud Hospital in Algiers. It focused on the immune histochemical profiling of a single patient with pituitary macroadenoma. Here are several histological sections, immune histochemically stained with different markers, among with what each of them indicates. So the first one on the left is marked with chromogranin A. The staining shows heterogeneous positivity with confirmed the neuroendocrine origin of the tumor. Second was marked with cytokeratins 8 and 18, showing an intense diffuse positivity reflecting epithelial expression of tumor cells. Next, with the TPIT marker showing a clear positivity of tumor cells pointing to corticotropic differentiation. Then with GATA3 marker, negative, consistent with absence of thyroid and parathyroid lineage. Then with the PIT1 marker showing absence of expression by the tumor cells, excluding somatotropic, lactotropic, thiotropic differentiation. And finally, with key A67 showing a proliferation index estimated at 3%, indicating moderate proliferation compatible with generally benign behavior. So all morphological and immunophenotypic features supported the diagnosis of a pituitary adenoma, TPIT positive. Microscopic examination reveals, as you can see with the photos on the side, a neoplastic neuroendocrine proliferation organized in clusters and trabeculae of monomorphic cells rounded to fusiform in shape with granular eosinophilic cytoplasm and moderately enlarged basophil nuclei. These features are consistent with pituitary adenoma. As conclusion, we can say that this technique serves for PITNET, the diagnosis and classification. IHC markers confirm the tumor's pituitary lineage and define its hormonal activity. For the prognosis and therapeutic guidance, histological grading use a key I67 and P53 and invasion status help predict aggressiveness and guide personalized treatment. And for the glioblastoma diagnosis, AHC confirms the glial and astrocytic origin, the differentiation of GBM from other brain tumors. So together, they move diagnosis and treatment from shadow to light, enabling a more precise patient-centered approach in neuropathology and neuro-oncology. Thank you all for your honored attention.
So Dr. Sampurnam is principal of Bhavani College of Nursing, Erode, India. She has 16 years and 6 months of teaching experience for UG, PG, and PhD nursing programs. She is a close friend to OLCIAS live conferences and also the prestigious member of Editors Board of OLCIAS journals. And the title of her talk presentation will be Meta-Analysis on Brain and Cognitive Science in Nursing Research. Today, she'll be joining with Professor Tracy and her student, Ms. Reshma.
Shall we start, Gezel?
Definitely, Doctor.
Yes. I request Reshma to start.
Good evening, all.
Good evening.
I'm Reshma from Bhavani College of Nursing, followed by Dr. Sampurna and Professor Price. Today, we are going to discuss about meta-analysis on brain and cognitive science in nursing research. We have done a quantitative research review on brain and cognitive science based on meta-analysis and effort sites. According to Ivory and Mangum, the study of brain and its relationship to mental processes forms the foundation of brain and cognitive science. Brain science, often equated with neuroscience, focuses on biological and physiological mechanism underlying neural activity, that is, electrical and chemical process occurring within the nervous system, enabling communications through the transmission of electrical impulses. According to Miller, cognitive science studies the nature of
Reshma,
mental
please wait.
representation.
Reshma, please wait. I request Gezel to move the slides. Thank you.
All right, Dr. Sampurna, I'll ask the teammate. Can you see the slide moving right now?
Yes, of course. I request Reshma to give command next so that they'll scroll the slides.
Yeah, definitely. That'll help. Thank you so much.
According to Miller, cognitive science studies the nature of mental representation and processes such as perception, that is, an ability to notice or understand something, attention, listening, watching, thinking about something carefully, language, system of communication, and speech and writing that is used by the people, problem solving, which includes a process of identifying the problem, determining the root cause, deciding the best course of action in order to solve the problem, and then finally implementing it to solve the problem. And decision making, the process of choosing a course of action from the set of alternatives. Together, brain and cognitive science aim to bridge the gap between biological mechanisms and mental phenomena. Next slide, please. Cognitive science and neuroscience have increasingly contributed to nursing research, especially in areas like dementia care, cognitive impairment, that is a memory disorder, mental health of nurses and students, interventions to enhance cognition, decision-making, or reduce burnout, that is an effect of a state of mental, emotional, physical exhaustion caused by prolonged stress. Next slide, please. Furthermore, according to Dehaene, artificial intelligence and machine learning have increasingly drawn inspiration from brain and cognitive science. This reciprocal relationship between neuroscience, cognitive science, and AI has deepened our understanding of both human intelligence and artificial cognition. Next slide, please. By synthesizing randomized controlled trials, quasi-experimental studies, and observational evidence, we can assess what works, what doesn't, and where more research is needed. Over to the session, Dr. Sampurna.
Next slide. Yes, okay. I'm Dr. Sampurnam from Bhavani College of Nursing. So I'll be presenting about the methodology of this research work. So as Reshma said, we operated meta-analysis. We have collected all quantitative data from few studies related to nursing research. And we included older adults, age above 60, and dementia patients, ICU patients, nursing staff and students. And we have done database from Google engine, like Medline, Embase, Siena, Psych4, and Cochrane, etc. And the outcome of this research is actually we were trying to search for cognitive function and its improvement. Yes, we found that cognitive functioning was improving with the help of certain interventions like cognitive training and even cognitive simulation and even rehabilitation. So after this rigorous literature review and meta-analysis, we found that it showed some promising effectiveness in improving the cognitive function. And next slide, please. Yes. So the first study on cognitive based intervention in older adults. Older adults were healthy sometimes even with mild cognitive impairment or with dementia. So all these three groups were there. And this study depicts that cognitive stimulation like varieties of activities they've given researcher, like enjoyable and social activities. Along with that, even cognitive training, they focused much more about on mental exercises like games, solving puzzles, and developing new hobbies. And cognitive rehabilitation, researchers have given some worksheets and visual imagery. So after giving all these interventions, they found that there was some improvement in cognition. And next, research related to nurse-led on pharmacological intervention for dementia. Here, nurse found that after giving music therapy, like physical exercise and reminiscence therapy, even aroma, they found there was some effectiveness in the cognitive improvement. So next study is on mindfulness-based intervention, MBI. And this MBA also showed some promising effect in improving the cognition of the clients. So this mindfulness-based intervention focused much more on meditation, especially, and even group activities. Next slide, please. Yes, intervention for healthcare professionals and nurses. It's one more literature review where we searched and we found that mindfulness intervention reduced anxiety level and stress level and even depression in nurses and even among nursing students. And for ICU nurses, this MBI was effective in reducing their burnout. And next study is on clinical decision making and critical thinking in nurses. So actually this metacognitive process is nothing but thinking about one's own thinking, you all know as such. So it was really helpful for registered nurses to think critically. So so far we've discussed 5 studies. One is cognitive, the other one is nurse-led, the other one is mindfulness-based intervention, and of course one more is on meta-analysis related to ICU nurses and something related to decision making. So all the 5 studies showed promising effect. Please scroll the previous slide once more, previous slide, so that I'll show the side effect size calculation. Previous slide. Yes, thank you. In older adults, a pooled standardized mean difference like 0.39 at the 95% clinical interval showed 0.32 to 0.44 for cognitive function. So this showed some promising effectiveness in improving the cognitive function after interventions like cognitive stimulation, cognitive training, cognitive rehabilitation, and even mindfulness-based intervention, which is really good for dementia clients. Yes. Next slide, please. Please scroll. Yes, next slide. Even next slide, please. Yeah. So synthesis and interpretation. So across population, like older adults above 60 years, dementia patients, nurses, and even ICU patients, etc., there is a promising effectiveness of non-pharmacological and psychosocial interventions that showed very modest and moderate effectiveness and with effective size in improving cognitive function and mental health and quality of life among older adults. Next slide, please. So we were trying to depict all these with effect modifiers and moderators. So what in our research, what it's a finding is in the sense, type of intervention is nothing but like cognitive training or simulation or mindfulness or brain stimulation was quite effective in improving the cognitive function, of course, the brain function of an individual, especially in older adults. And intensity and duration, while talking about intensity and duration, longer duration was much more effective and the durability was also good. In population characteristics, basically, this cognitive status, age, and dementia severity was playing a vital role in improving the cognitive function of the particular individuals. And setting, actually, it is done in nursing homes and hospitals and even in community areas. Intervention, usually nurse-led intervention and specialized interventions were comparable, and both were effective. Next slide. So with this over to Pricey.
Yeah. Hi all, I'm Tracy, Professor.
I'm sorry, Professor Tracy, you are not audible here.
Hello, am I audible now?
Yeah, you're audible now.
Okay. Yeah. Hi all, I'm Professor Tracy from Bhavani College of Nursing, India. Now we have about the meta-analysis on brain and cognitive science in nursing research. So coming to the discussion part, according to Gord and Russia, in clinical nursing practice, cognitive and brain-based interventions, which is including cognitive stimulation, which is a non-pharmacological treatment for people with mild to moderate dementia that uses themed group activities like solving puzzles, cooking activities, and physical games to improve their cognition and quality of life, and neurocognitive rehabilitation, which is the multidisciplinary therapeutic approach to help individuals with related injuries or disease to improve cognitive functions like memory, attention, and decision making. Some of the examples of this neurocognitive rehabilitation or relaxation therapy, music therapy, etc. So this both demonstrated a positive effects on patients' cognitive performance and emotional regulation. Interventions are safer and more feasible when delivered by nurses, especially non-pharmacological ones, which is importantly given constraints in clinical settings that include cost, side effects of drugs, patient comorbidity. Next slide, please. Next slide, please. Yeah. Neuroplastic changes, which is also known as a brain plasticity. The brain's lifelong ability to reorganize its structure and function and connections in response to experiences, learning, injury, and environmental stimuli. The changes can be both functional or structural. For example, increased cortical thickness associated with some interventions like mindfulness-based interventions, which is a therapeutic approach again that combines psychological principles with mindfulness meditation to improve mental and physical well-being. So they treat conditions like depression, anxiety, stress, etc. So suggest that these interventions do more than symptomatic relief. They may alter brain structure and function. Nurse education incorporating principles from brain science, including motivation, reducing stress, attention into teaching improves learning outcomes. Next slide. So, according to part B, nurse-led interventions have shown measurable benefits in improving executive functions and attention, particularly among patients with dementia, which is a progressive decline in cognitive function, and also among patients with stroke, which is a medical emergency that occurs when the blood flow to the part of the brain is disrupted, causing brain cells to die within minutes, even leading to death, or post-operative cognitive decline, which is also termed as POCD, which is a decline in thinking and memory that can occur after surgery, especially for older adults. So these outcomes reinforce the role of nurses as key facilitators of cognitive health, supported by neuroscience experiments. The nursing care can influence neuroplasticity. Next slide, please. According to authors like Ivory, Mandel, some of the clinical perspectives are found like brain-informed nursing interventions enhance holistic care by considering not only the physical but also the cognitive and emotional dimensions of the patient health. So, cognitive rehabilitation and mindfulness-based interventions grounded in cognitive science can improve patient engagement, reduces anxiety, and enhance recovery outcomes. Next slide. So this holistic approach includes all the physical, emotional, spiritual, intellectual, occupational, environmental, financial, and social well-being of the patient. So according to Park and Lee, again, the pooled evidences from randomized control trials demonstrated that brain-based and cognition-focused interventions, like brain-based simulation, which involves creating a computational model of brain structure, like brain structure and also the function to understand the brain process, to predict the disease progression, the design treatment, and develop new technologies like robotics and brain interface.
For instance, for instance, virtual reality simulation and cognitive training programs showed moderate to large effects on knowledge, retention, and problem-solving and decision-making skills. Evidences from quasi-experimental studies also reinforces these findings. For example, studies employing quasi-experimental designs reported that repeated exposure to brain-based simulation and mindfulness training and cognitive simulation led to measurable gains in executive functioning and emotional regulation of the patient, which is a positive aspect. Next slide, please. According to Golb and Verschoor, for instance, longitudinal observational studies have shown that nurses who engage in reflective practices and cognitive rehearsal maintain higher level of situational awareness and decision-making accuracy in clinical environments. Next slide, please. So coming to the conclusion, where the meta-analytic evidence supports that brain and cognitive science-based interventions, so including cognitive training, stimulation, mindfulness, intervention, non-invasive brain stimulation, etc., all are effective in improving cognition, mental health, and quality of life in various populations relevant to nursing. However, next slide, please. However, heterogenetically or short follow-ups and variable quality of evidence limit definitive conclusions. So future nursing research should focus on refining these intents as we discussed about like cognitive training or stimulation or mindfulness based interventions and non-invasive brain stimulation. So we have to focus, nursing research should be focusing on these interventions and understanding the neural mechanisms, ensuring sustainability and integrating brain science into both care practice and education. So these are the references which we have used. If you have any doubts, you can clarify with us. Thank you.
All right. Thank you so much to Dr. Sampurna Webster, Professor Tracy, and Reshma for the insights on meta-analysis on brain and cognitive science in nursing research. While we were having this last talk presentation for the day, we collected a few questions from some of our viewers and listeners. These questions are for Dr. Yunus, Dr. Habchi till now. So I would like to ask them to please address the questions here. Okay.
Well, the question addressed your findings highlights that Broca's aphasic patients seem to compensate more effectively in linguistic compositional tasks than in numerical ones, possibly due to the availability of semantic and contextual cues. Well, from your perspective, could cue-based rehabilitation strategies, particularly those leveraging semantic context, be systematically applied to enhance recovery, not only in language, but also in numerical cognition among such patients? Well, first of all, by its nature, it's a bit kind of impossible almost to have semantic or contextual cues in mathematics, because, well, mathematics is very abstract. Of course, it has some common features with language, but in language we can directly see context or semantic precisely in terms of cues. But in mathematics, it would be a bit difficult just to have purely mathematical, semantic, and contextual cues. So instead of these, maybe with the integration of language, we might have such a rehabilitation. So having a context where, for example, like we're gonna have we're going to supermarket and we're gonna buy apples, or I don't know, some other stuff. So like I have 2 apples, and then I'm gonna have my mother asks also another apple, so 2 plus 1, for example, in this case. So at the end, how many apples am I gonna have? In such a context might help in rehabilitation strategies, but honestly, this is not such a mathematical cue. This is still, I think, can be considered as language-based contextual cues, because as I mentioned before, mathematics does not have such a direct contextual cues. Maybe it does have, it exists, but I don't think, I mean, it might not be very easy for patients to integrate such a pure mathematical context. So I guess maximum thing is adding such language-based daily life contextual cues to the strategies. Yeah, I mean, that's going to be my answer though.
All right. So I would like to share that the question was from Dr. Bruno Silva Costa, a neurosurgeon from Brazil. And thank you so much for picking up this question, and thank you so much for addressing the question, Dr. Vural. It was informative. And okay, let's move to the next question. The next question was for Dr. Habchi, I guess. Dr. Habchi, can I have you here on the screen, please? I hope you're here in the meeting room.
Yes.
Yes.
So
Yes,
for the
okay.
first question,
Yeah.
here, could you elaborate on how this marker may guide the treatment decision or influence personalized therapeutic strategy in neuro-oncology? So I answer to this question in the part of chat books. So here we don't interpret this marker in isolation. We integrate them with radiological invasiveness, especially in the case of pituitary adenoma. Also, we introduce the hormonal phenotype for the case of pituitary adenoma and molecular profile for the case of glioblastoma. So for the strategy we use here, all the data in order to contribute to one strategy, and we use this glioblastoma, this marker. For instance, when we have Ki67 more than 40%, here we correlate with a faster growth. So we must plan earlier control by MRI, and we pass directly to other strategy, therapeutic strategy. This is for the case of glioblastoma. In the case of pituitary adenoma, here we use especially the invasiveness of this king of the brain tumor with Ki67 marker. When I have this marker more than 3% with the number of meters more than 2, and also I have a positivity of P53, I do the histological gradient, grade 2, invasive and proliferating tumor. So I think that after 3 or 4 years, I will have recurrence of this tumor. So I do another therapeutic strategy. So I accelerate the follow-up of this patient. So for the second question, the integration of histology and molecular profiling is key strength in your work, your experience. What are the main challenges in translating this? Yes, we have challenges. It is in the clinical and in our routine clinical practice. So exactly, what is the difference between the invasive and recurrent tumor forms? For the invasiveness, the indication is radiological, the use of MRI. I confirm the invasiveness by using the MRI. And for the recurrence, I choose, for the case of pituitary adenoma, I choose the radiological sign with the use of the histological gradient. So this person asked a question: what is the difference between the invasive and recurrent tumor forms? For the recurrent tumor forms, here I use the histological grade. This is why I present this conference. When you have the grade 2B, you think that in the future we will have the recurrence of your tumor. And how I do this classification, this grading, by using the MRI and also the immunohistochemistry. I use the marker Ki67, P53, and the number of meters. This is in order to do the grading of my tumor. This is how to have this grade 2B, and after grading my tumor, I will have the follow-up of this patient. Grade 2B, I will have a recurrence of this tumor. And for invasiveness of this tumor, I will use the MRI. The MRI, when we have the invasiveness of cavernous sinuses, here I do this classification. This is my answer. So for the molecular biomarker, the molecular data indicate when the brain is ready to be trained, and functional data indicate where the brain is. The train is for the place and the time.
All right.
So molecular data for the time and The functional data indicate the place. This is my answer.
Perfect. Thank you so much to Dr. Habji. The question was from Daukali Zohra, Professor Daukali Zohra from Morocco. Thank you so much for addressing the questions, Dr. Habji. These were informative. And now let's move to the next question. The next question is for Dr. Sampurnam Webster. Dr. Sampurnam, do we have you here in the meeting room right now?
Yes, ma'am, I'm here with you.
Yeah.
Please
Should I
address the
read
question.
that question out for you?
Yeah, please read.
Okay, so the question is, your meta-analysis highlights the effectiveness of nurse-led non-pharmacological interventions such as cognitive training and mindfulness. Based on your findings, which of these interventions appear most sustainable or practical in everyday clinical nursing settings, especially in resource-limited environments?
Thanks for addressing the question. And see, this meta-analysis focuses on all areas only, but still I could say in-depth analysis and effect size-based calculation, I could say that mindfulness-based intervention really works out in improving the cognitive function. Comparatively, like stimulation, training, and rehabilitation, mindfulness-based intervention really works more comparatively. In case of nurse-led, single non-pharmacological intervention, apart from mindfulness-based intervention, next to mindfulness-based intervention, cognitive training works little. Thank you so much.
Thank you so much to Dr. Sampurnam. The question was from Dr. Daukali Zohra as well. Thank you for the question and addressing the question, Dr. Sampurnam. I think there is one more question, Dr. Sampurnam. The question is, it's fascinating that some interventions show measurable neuroplastic changes like increased cortical thickness. Do you believe neuroimaging or physiological markers should become a standard part of evaluating cognitive interventions in future nursing research?
Yeah, of course. As per the question, images also can reveal cognitive impairment. Of course, any impairment also it can reveal.
Thank you so much
Thank you.
for addressing the question, Dr. Sampurnam. And
Please address the question, Gezel.
okay, let me read out the question. Across your studies, we see different perspectives of brain adaptation, from neural reorganization after left hemisphere damage to molecular insights in brain tumors and cognitive training in nursing. How do each of you view the role of neuroplasticity as a common thread linking these very different areas of brain research? I think the question is from all of our speakers for the day.
Well, I believe the question might also refer to my research regarding the left hemisphere damage.
Yeah.
So I can answer if you let me.
Please do. It is the question
Okay.
from our speakers.
Okay, thank you. Yeah, thank you. Well, so neuroplasticity exists. It is there. It's gonna do its job by the biological part, by evolution and based on biology. Yes, sure. But what can we do is supporting this neuroplasticity. Well, how can we support? Well, the answer is clear. The answer is rehabilitation. So not only neuroplasticity, but also integration of neuroplasticity with rehabilitation is, I believe, the key for aphasia. Well, not only in aphasia, but also in other type of neurological disorders and conditions. So in my opinion, well, and I believe that all people dealing with neurology, neuroscience, they will also think the same, that neuroplasticity is there, it exists, it's going to do the job. But to support this process, we should also do additional things, which is at the end the therapeutic processes, which is rehabilitation. So it should go together, head to head. Thank you.
Thank you so much to Dr. Vural for taking up the question and answering it very informatively. Okay, there is one more question for discussion. Each of our presentations today highlights a unique bridge between research and real-world outcomes, from clinical recovery to tumor diagnosis and cognitive rehabilitation. In your views, what key steps are needed to translate these diverse neuroscience findings into everyday clinical or educational practice?
Yeah, I'm Professor Crazy. I'd like to answer this question.
Yeah, please go ahead.
So to bring neuroscience findings into the real practice, we need strong collaboration actually, like strong collaboration between the researchers, the clinicians, and also the educators. So evidence-based methods should guide care and teaching, supported by the training, which helps the professionals understand the brain principles. So I think using these technology like neurofeedback or cognitive training tools can enhance the outcome of this. So, but continuous evaluation is a key to make sure these approaches are truly benefit for the patient and also the learners. Thank you.
Yeah, thank you so much for taking up the question and answering it. Thank you so much, Professor Prezi. And I guess Dr. Hapchi also gave a add-on. Would you please repeat here on the screen, Dr. Hapchi? So the LinkedIn live stream attendees also can hear up to that.
Okay. So for the question, here one question about what key steps are needed to translate this diverse neuroscience finding into everyday clinical or educational practice. Here, we must do a unique strategy. You make all this neuroscience as a result for results usable for every day. Here, we need to unify our measure, our strategy, therapeutic strategy, so the same clinical examination, imaging, MRI, or CT scan, and also or the cognitive skills. So all these unified measure contribute to do a good result. And also, we turn study into simple protocol. We use one protocol for all the patient, for all the kind of the tumor. And we organize multidisciplinary routes for our patient. This is my answer.
Thank you so much for the add-on, Dr. Hapchi. Great. So I would like to ask if any of our speaker still have any add-on to any of the question, please. You're most welcome. Thank you so much to Dr. Vural, Dr. Hapchi, and Professor Prezi for answering the questions, for providing their discussions and add-ons. I repeat, if any of our speaker would like to give an add-on to any of the question, please. With that, there is Dr. Vural. Would like to give an add-on. Yeah.
Thank you. Yeah, I just want to add last piece before ending, especially regarding the question on key steps for translational science perspective. Well, I think the collaboration is a key for neuroscience or any science regarding brain and cognition, because it is very interdisciplinary by its nature. So we should work all together, and I believe that is the key to reflect insights from research to clinical and educational practices, and multidisciplinary and collaboration are the two key terms, let's say, to take as message from today's, I think, overall presentations from my side at least. And thank you once again for having me today. It was very good. It was a pleasure, and I hope to see you in the next conferences maybe. Thank you.
Definitely, Dr. Vural. It will be our pleasure to have you back in our future events. Yeah. So here we had all the add-ons and the great insights from our speakers. I hope you all enjoyed as well as got so much knowledge with me. Please excuse me for a while. All right, thank you so much. Now I would like to thank to all of our speakers and attendees for today's event. Okay, so it's time to announce about our next event. So next event is planned for January 3, 2026, and the event's name is Neurology and Neurological Disorders 2026. We would love to welcome you all of you to our next event. Please do register right now so you can save your slots, and we will come up with some more insights. And if we'll be planning any seminar in between, we will definitely notify all of you with emails, and you can come up on our website and keep checking, please. And please do not forget to provide your precious feedbacks to us. A great pleasure for us as well, Dr. Habji. Thank you so much for being such a great support. Definitely. The participations, questions, and insights have made the session truly enriching. And special thanks to all of our researchers and editorial board members who were watching this whole event, the live stream or with other mechanisms, and they provided their insights and the questions as well as. Thank you so much to all of you. So this was it for today. Thank you so much for joining us for our today's event, which was on brain and cognitive sciences. And we will definitely meet in our next event. Till then, please take care of yourself, and namaste from India. It was Ghazal Johar, and I would love to welcome you all in our next event. Thank you. Thank you so much to Dr. Vural, Dr. Habji Nabil, Dr. Sampurnam Webster, and all of our dear attendees and all of the team members. Okay, it is the time when we will leave this event and we will try to prepare for the next event, right? Okay, bye-bye to everyone. Take care.
Bye-bye.
Bye-bye, Dr. Habji. Thank you so much for joining the event today.